Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindigocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today I'm joined by my friend and colleague Dr. Singer, Director of Clinical Research at the Medical Center Ophthalmology Associates and Clinical Professor of Ophthalmology at the University of Texas Health Science Center in San Antonio, Texas. Welcome, Mike.
Arshad, great to be here.
I'm so excited to have you here because you and I have worked for so long together. And today we'll be discussing the latest trial data and real-world studies on approved and emerging therapies for diabetic macular edema. When I think of diabetic macular edema, one name comes to mind is Michael Singer. When I was in training, you have done all this work on steroids already, and you continue to innovate the field. So such an honor to have you, Michael, here, because this is an opportunity for our audience to learn about the latest innovations in management of diabetic macular edema. But as you know, this podcast is different. Before we get to the subject, we actually want to know who Michael Singer is. And I know you have a lot of hobbies, but before we get to them, tell me how you ended up in retina.
I ended up in retina because I always wanted to go into ophthalmology, because when I was a kid, I had seen lasers making holograms, and I thought that was really fascinating. So I used to make holograms in my house, and I was really into optics. So optics got me into wanting to be an eye doctor, how the eye worked. And then I was inspired by people like Yale Fisher and Rick Spade to see that retina really had value, because retina surgery is really interesting and cool. And medical retina had such a huge unmet need that there had to be potential somewhere on the horizon that we could make a difference in.
So that's a great story. So you end up in retina, obviously, and what do you do outside retina? So I know you have many hobbies, and you love music too. So tell us, what is your favorite hobby?
My favorite hobby is something that I do every day is I swim. So I swim every day because for me, being a very type A type individual, it's the only time that I shut my brain off and I really get a chance to think about things that are going on. I'm lucky enough to put headphones on the back of my goggles, and I swim every morning very early. And over the course of an hour swim, I'm able to think about everything that happened the day before, what's another way to look at it, and really come up with a basic philosophy of how I live life, which is people live life either in the future or the past. If you live in the past, you're a reminiscer or a regretter. In the future, you're anxious or excited. And being a type A guy, I want the future, and I'm always excited about the future. That's what's perfect for retina, because everybody's excited about what we have coming down the pike.
That's pretty cool. I didn't know that. So you swim for an hour every morning?
Yes.
Is it 3 a.m.? Because you're up by 4, I know.
It's at 5 in the morning.
On calls, 5 in the morning, okay. And I know you like music?
Yes. I play guitar, but I'm horrible, but I appreciate music, and I love the opportunity to go around actually the world and see a lot of the 70s, 80s, and 90s bands to enjoy an opportunity not to work hard and play hard. So again, I truly believe if you go somewhere for a meeting, you should take a moment, look around, enjoy the ride. My enjoying the ride and like looking at the roses is going to concerts, which is great. And then
I need to take that advice because I don't do anything else, just the meeting. And one thing I think the audience don't know about you is that you actually own an ice cream company.
Yes, basically, but 15 to 20 years ago, I created a diabetic ice cream company that was ahead of its time, that essentially was the basis, believe it or not, for combination therapy. Based on the concept, if you looked at two different types of sweeteners, think of it as Splenda and aspartame. And if these had a value of 1, you'd expect when they put them together it's 2. It actually is 4. It's called synergy of sweeteners. And that literally was the basis of combination therapy of anti-VEGF and steroids.
Great. So that's a good segue to actually discuss some of the newer therapies and some of the emerging therapies, as well as established therapies for the treatment of diabetic macular edema. So on the subject of bispecific or combination therapy, let's talk about faricimab. I know you've been involved with the program for a long time. You have presented the data on faricimab for multiple programs. It was the first bispecific antibody for treatment of retinal diseases, approved in 2022 for DME and neovascular AMD. And now we have 3-year plus experience using it. And you're, of course, part of our Truckee and Tahoe group where we looked at real world data. But recently the RONEX data came out, which is a 4-year study, and you have presented that too. So tell me a little bit about some of the key learnings from the RONEX study of faricimab in patients with DME.
So RONEX obviously was one of the longest extension studies ever done in anti-VEGF for 4 years, and really looking at a patient population who were well treated, but we wanted to figure out how they could do and would the duration continue, because initially we learned in AMD, and I wrote Horizon, that if you stop giving shots or you don't give them frequent enough, you lose vision. Are we able to keep the vision and maintain it? And what was really nice is when we looked at over 4 years, 80% of people were able to keep Q12-week dosing on faricimab. And the aflibercept people who were initially randomized to that arm got transferred into the faricimab dosing. What I thought was interesting in that group was that although they were doing very well when looking at DME activity, somewhere in 80% range had control, but 20% didn't. And the interesting, when you transferred them over to faricimab, you gained about 9 percentage points. So over 90% of the entire population, but especially the aflibercept group, realized you were leaving some disease activity on the table, and making that transfer really was actually clinically meaningful to people like us to figure out, is there anything we can do for these chronic people? Actually, you can make a difference even for 3 or 4 years later.
No, that's a really good point. I think that's where the mechanism of action kind of shines, is that now we have been treating chronically with aflibercept and switching to a new mechanism of action with bispecific, you are able to control disease. And then what about safety? Because I know it was a safety study because we were looking at 4-year safety in a large number of patients.
The good news, safety was really good. I mean, there was no vasculitis. There was nothing that you really had to worry about as we treat people over time. And again, it was one of those things that really kind of reaffirmed the fact that the great results we got at the first 2 years could be maintained with longer intervals without sacrificing vision.
Great. And then, of course, you're part of the Truckee and Tahoe studies. As I said, Tahoe, we have seen disease activity benefit by switching to faricimab. We're seeing increase in durability. And I know far retina DME has been a study that's looked at iris registry in terms of benefit of faricimab. Can you overview some of the key points from there?
So it's interesting, initially given the way people treat far retina, because the question is clinical practice, not clinical trials. So you'll take a drug and then your retina specialists, or we call mavericks a little bit, they kind of do what they want to do. But even in real life, we looked at the number of mean injections in year 1 was 9, and they became about 4 in year 2. And I think one of the reasons that the numbers go down is the Ang2 component takes a while to kind of gear up, because Ang2 is a mature vessel stabilizer. And initially in DME, these vessels are relatively new, where the anti-VEGF really has a pack. But I think we watch the data over time, your need essentially for more injections go down. In addition, diabetes probably slows down as well. But it's much more tolerable for patients that if I only have to come in once a quarter, I may get higher compliance.
That's a really good point. So how is it performing in your hands? Is it consistent with what we have seen with real-world studies and clinical trials?
Yeah, I think it is. I mean, obviously, everybody's a little different, and you'll find patients that are more receptive to faricimab. Some are more receptive to aflibercept. You'll have a majority of switchers will go from aflibercept to faricimab, but they go the other way as well. So it's still, we still have to personalize medicine. But again, overall, I think the second generation agents are literally a step above the first generation agents, not only in terms of potency, but also in terms of duration.
I think that's a really good point. So now let's move on to the next topic, which is another innovation in the field, is aflibercept 8 milligram, which is a higher molar dosing of aflibercept 2 milligram. And this was obviously studied in the PHOTON study for DME and got approval based on the data. So recently we have seen the PHOTON long-term extension data. And what do you think of that data? Can you overview that data and how it impacts clinical practice?
So I think one of the things that's interesting, similar to the REGENXBIO trial, the people who were in the 2 milligram group transitioned to the actively studied group. So the 2 milligram group in the aflibercept, in the trial, basically in PHOTON, went to 8 milligram. And what was interesting was, just like we said there was potentially disease left on the table when they switched in REGENXBIO, there was potential disease left on the table here in terms of OCT thickness. Because when you went from 2 milligram to 8 milligram after the first shot, you were able to get an extra 54 micron reduction on CST. Again, to say, look, switching these people off just because accepting that there's residual fluid, there's nothing I can do, actually doesn't really cut it anymore if there's something better out there. So that's really nice. And then the other thing which I thought was amazing is you start transitioning people over, and then once they stop getting medicine, it takes longer to get fluid to reaccumulate, which is another way of showing a duration play, because you're either going to be stronger or longer, and once you've got the stronger, then it becomes longer. So again, second generation medicines really have their place in taking care of a lot of these chronic disease patients that we've been following and treating over time.
Yeah, I mean, you and I are old enough to remember the transition from nothing to steroid to anti-VEGF, and then transition from ranibizumab to aflibercept 2 milligram. So it's kind of nice to see that over the last 20 years, we went from first generation to second generation. So how is it performing in the real world for you, aflibercept 8 milligram for DME?
I mean, I think it works well for certain people, for sure. I definitely see there's lots of value in these patients that are hard to treat, that may have some response, but not all the response you want. That there's definitely a VEGF sensitivity, and I think having a higher molar dose will get them dry, or diabetics are notoriously non-compliant, and because they're notoriously non-compliant, I feel better when I have people on 8 milligram and they miss a visit, because I know in the vast majority of people, they can go 3 or 4 months and it's not going to be a big deal, because again, the medicine's still working.
Those are really good points. And so let's move on to the next topic. Something that's really close to your heart is dexamethasone. You're really involved with the development of it and done so much work on the efficacy and safety and long-term outcomes. So what's new for dexamethasone? Any updates from you, and what's going on in your practice? How are you using it compared to these newer agents where you can sometimes go 3 to 4 months? What is your paradigm?
So, my paradigm is, let's start what's new. So what's new is, for the longest time, there weren't any really new studies looking at dexamethasone for the treatment of DME. However, this year, actually Barry Cooperman recently presented this at CTS, the early dex medicine, the early dex trial, and I'm part of it as well, and be presenting it over the course of the year. And what we wanted to look at in this situation, it's a retrospective study, but looking at people who had 3 shots, that essentially, how did they do if they stayed on to go shots 4, 5, and 6 of anti-VEGF, and this essentially was either ranibizumab or aflibercept or bevacizumab, or if they transitioned over to dexamethasone implant. And what it showed is the people who transitioned over to dexamethasone implant did significantly better in terms of increasing visual acuity and decreasing central subfield thickness than the patients who were left on shot 4, 5, and 6. And that manifests itself not only in terms of mean BCVA, where it's about 8 letters, it actually increased the number of patients who were 2 and 3 line gainers. Wow. So it really showed there was, again, we left something left on the table. Even though VEGF is great, not all DME is VEGF mediated.
I mean, you've been saying that for a long time, and I think all of us agree with that. So this is actually very meaningful data. So how does that change, like this data, does that change anything for you? Because I know you already use a lot of dexamethasone, but what would you say to the audience that don't use any steroids? How does this data help them?
I think the concept, treat earlier. I mean, you wait forever and you think doing the same thing over and over again is going to get you a new response. And the reality is, if we look at it, even you look at the original early study, which essentially looked at patients over time and said, if you gave 3 in a row and you didn't get any improvement, you weren't getting improvement. Starting people earlier and putting steroids in the back of your head, not in the back of your head, but more in the forefront of your treatment plan to say, look, I'm not getting anywhere looking at the OCDs. Why don't I try a steroid? The advantage is, obviously we always worry about IOP and cataract, but getting a cataract after 1 dexamethasone injection is incredibly low. And IOP, the numbers are pretty stable. Even if it goes up, it's going to go down. And see whether or not that mechanism of action may make a difference. A lot of times it does, because I've rarely seen people that have no reaction after 1 anti-VEGF have reaction after 3. I mean, I've seen it chip away, but I've never seen nothing. And it's just a different way of looking at things. And one of my concerns is that if you don't think about it, and if you teach residents and fellows not to think about it, it won't be part of their arsenal. Why not use every tool in your toolbox if you can?
I agree. I think it's an important tool in your toolbox, and I think I do exactly the same. Those patients that need dexamethasone will declare themselves very early. You don't need to wait for 12 or 15 or 24 shots. You can find out very quickly. So great work by you, Barry, and the team to really enlighten the community about the benefits and how to utilize dexamethasone. So on the topic of dexamethasone, right? So this, dexamethasone you're talking about is intravitreal implant, but we also have very exciting program that's looking at dexamethasone in eye drop formulation, and this trial with OCS-01, the Diamond program, has Diamond 1 and Diamond 2 studies, and they're fully recruited, and we are expecting data next year. Can you tell us a little bit about data to date from the stage 1 of the Diamond 1 program, where they actually looked at dexamethasone eye drops, compare it to placebo eye drops?
So I think it's really fascinating that the formulation of in OCS-01 is really intriguing to me, because you have really great penetration. Because a lot of times you think, well, we used steroids and it didn't make a difference for DME. Why is this different? I think dexamethasone is a very potent steroid. I think the fact is that we load patients 6 times a day to start with for 6 weeks, and then we cut it down. And I think we get really good results. I mean, if you look at the data is essentially you had 7.2 letter gain at 6 weeks and 7.6 letter gain at week 12, and again, you had 27% of people that were 3-line gainers. So there's been, a lot of these patients weren't treatment naive; they were previously treated. So again, this shows another way to give the medication and basically work people through steroids to say, look, obviously it's not approved yet. Assuming it gets approved, though, I think the treatment burden goes down and the compliance goes up if I can take a drop and not get a shot. And for those people that are starting early, there's really very little downside risk. Yes, there's risk of cataract and IOP, but it's not like the implant's staying there. It's a drop that you can stop. And those people who did have pressure, when you took them off medication, the pressure went back to baseline.
No, I think that's a really good point, Mike, because it's a drop. So if you have any side effect, you can stop it. On the flip side, since it's a drop, we can implement it much earlier, right? So you and I are watching some of the DME patients because they're 20, 25. Right. They don't want to get a needle in their eye. So I feel like this may have more potential in terms of treating broader patient population. What are your thoughts on that?
I agree. DRCR did Protocol V with very good vision, and they said people who were 20, 25, just like you said, you could watch, but they still had they still have paracentral edema. And again, our numbers may not manifest it, but their quality of life does. And having them try a drop is an easy way to do it and see how they do and see if it's responsive to it. And it'll also give you the understanding the other way around. We always talk about people not responsive to VEGF or responsive to steroids. There are people that get a responsive to not responsive to steroids, that be more VEGF mediated. So I think it's an easy way to start that's very low risk for both the practice and the patient, and it'll give you a good way to say, look, this may be something we want to go forward with.
I think that's a really good point, Mike. So the next topic is tyrosine kinase inhibitors, right? Very exciting, paradigm-shifting therapy, possibly. We have 2 programs in phase 3, OTX-TKI, as well as EYP-1901. And EYP-1901 was actually evaluated for diabetic macular edema, and you actually shared the first time results at the Macula Society in February this year. So tell us a little bit about what is EYP-1901 and some of the key findings from the Verona study.
So TKI stands for tyrosine kinase inhibitors. They're a pan-VEGF blocker, and they block different forms of VEGF. And what's different about them than our typical anti-VEGF, they're given sustained-release implants. And they're injected over time. And what they showed is that those two programs are going on right now for AMD. Verona was the DME trial. And what was nice about the Verona, basically people got one shot, and they got one shot of aflibercept, and we watched patients over time. The feeling used to be that you had to pre-treat people with tyrosine kinase inhibitors with anti-VEGFs and get all the VEGF out of the way, and then the TKI would be a maintenance drug. We learned from this in DME that that's not true, that you can give a TKI straight off the bat in treatment-naive patients, and you can get visual improvement. You got visual improvement as early as 4 weeks, and at 6 months you gained 7 letters, which is really nice, and you actually lost 76 microns in terms of swelling in the eye, and 73% of people were supplement-free at 6 months. So the good news is having a medication that you can give that doesn't have side effects, although I'm a big steroid believer, TKIs don't have cataracts and don't have IOP. That really is something that's going to be a good alternative for our DME patients, because then you'll treat patients earlier, patients who are younger, all patients with glaucoma, all these things that are relative contraindication to steroids. The TKIs may be our next arsenal, the next tool in the toolbox.
That's a really good overview of EYP-1901 and TKIs in general. So we talk about second generation treatments that are injectable. We talked about dexamethasone implant. Obviously, you've also done work on longer duration DME implants. Then we talk about potential topical treatment. The data is reading out next year. And then we talk about TKIs. But one thing we haven't talked about is the port delivery system. Diabetic macular edema patients tend to be younger. They tend to be working. They have multiple doctor's appointments. You have done that work a long time ago, showing the burden is very, very high. You also did work where we participated with you in terms of no-shows in clinic, where you showed that DME patients no-show a lot, whether they're new patients or they're established patients. So port delivery system is a surgical device, as you know. It's approved for neovascular AMD, diabetic macular edema, and recently for diabetic retinopathy. So what are your thoughts on having sustained delivery via the port delivery system to control disease in these patients who tend to be non-compliant?
So port delivery system is a fascinating device. We've been involved in all the stages of the trials for both AMD, DME, and DR. And again, for diabetic patients, they understand the concept, right? Because how do most people want to control their blood sugar? They don't want to take daily or hourly shots of insulin. They want to get an insulin pump. So this is literally is an anti-VEGF pump in their eye. Right now it's ranibizumab, but eventually it'll probably be a Dutafab that they'll put into the port delivery system, and over time it diffuses out. It basically works on fixed principle from higher concentration to lower concentration. It's put at the pars plana. It is a surgical procedure. What's amazing, you've done a lot of work on this and been actively involved in the process improvement, because it really has gone through generational shifts, not only in terms of surgical technique, but also in terms of the actual implant. It was refitted, and all the problems they had before were actually worked out, and these second generation implants are really nice. What's interesting, both in AMD and in DME and in DR, honestly, the people who've got the implants in their eyes and have worked well are asking, when am I getting the other implant done? I'm tired of getting shots, and you got this great thing over here. I take a shot every 6 months, they're refilled every 6 months, but I'm getting shots in the other eye. And you always look at these people in trials and you see the OCT where the right eye is dry as a bone and the left eye is like lots of swelling, and they're coming in every month. But you can see that really sustained release, because that really is sustained release over time, is fascinating. So again, I think for a diabetic who essentially has issues of noncompliance and may not make it in the office, having to come in every 6 months to get a refill, they may not even need it actually in the early phases. For AMD, actually, it was 13 months. They didn't show that. The studies weren't done, but I'm positive, just like we do everything else, we'll see how far we can push it now that it's approved. And I'm sure in people who have disease that's easily manageable, you're going to get longer than 6 months going forward, which is great because these patients essentially, we're actually 4 of 25 visits they make to lots of physicians over time. So again, you can sleep at night if they miss a visit.
Yeah, I think that's a really good point. So I think talking about that, during COVID, we actually had many patients who no-showed. The patients with the port delivery system did great.
Right.
Because, you kind of had that security built in that they can go 6, 9, 12 months or even longer. It was a median time to refill in lateral was 15.8 months, as you were mentioning. So I think the key is that, of course, a surgical procedure, so, make sure you discuss risk and benefits. But we have seen great results in the Pagoda trial. We just published the paper recently in JAMA on it, and I think it's a great advancement for the field, proof of concept for sustained delivery, as you mentioned, for patients with DME. And I joke around that I get a lot more hugs because of port delivery system than I ever did from my patients, because they are so happy that they want it in the other eye. So actually, patients who receive implant in one eye from neovascular AMD studies, one in the other eye. So when commercially it was available, we had multiple patients doing the fellow eye. And recently I implanted one patient who was one of the first patient in the Pagoda study, finished, and then we have the FDA approval, received the implant in the fellow eye. She's been on it for last 5 years. She was in the Pagoda study, just getting every 4 to 6 weeks injection, and she hates injections. And this was great for her to receive the implant in the fellow eye. So I think it's great to have that. As you said, it's gone through a generational shift in terms of learnings, right? Any surgical procedure goes through a decade or 2 decades of learning. I mean, when Machamer started vitrectomy, those instruments were huge, and there was such a high complication rate. Look at what we are doing now. So I think you make a really good point. And I think proper surgical training and really doing the steps right is the way to go. So this is great, Michael, to have you and learn about the latest updates on diabetic macular edema, you being a world-renowned expert on it and a good friend, obviously. But in the last few minutes, we also ask our faculty some other questions. And the one question I really want to know is, you have done so much for the field. You have come up with new treatments, you have generated great data, you have asked good questions, you travel more than anybody, you're speaking around the world. My staff loves your talk when you come to Reno. You have, presented everywhere in the world, and you're everywhere. But out of everything, and I know you are a family man too, spending a lot of time with your son and your daughter and your wife. So what is the biggest career achievement that you're most proud of? Let's share that with our audience.
I suppose, in terms of really what am I most proud of, I'm most proud of that I had the opportunity to influence students and fellows and other clinicians, that a lot of the things that we came up with, like combination therapy, a long time ago, are now becoming adopted and considered standard treatment, or definitely thought in the treatment paradigm. So I feel like we make a difference in that. And again, if I get the opportunity to teach something new to somebody, I feel like I've, given back. And then, if you wanted something more concrete, in terms of accolades or thing, when I got into the Retina Hall of Fame about 7, 8 years ago, that really meant a lot, because it was recognition from my colleagues that were, making a difference in the world. But again, I ran an ice cream company, I told you, and I was diabetic, and I really thought to myself I could change the world by giving healthier food, and which was slightly naive. But when the company went out of business, I said, well, maybe I should just change my world, make a little change. And I tell everybody I'm about 1%. If I can be 1% of everything you see on TV or anything you do, I've achieved my goal.
No, you have trained so many people, inspired many of us, including myself. So thank you for doing that. And then, you're not retiring now, but the question I always ask is, when you retire, how do you want to be remembered as? And I'll tell you how I'll remember you, but you tell me first.
So I'm going to answer your question slightly differently. So what are the 2 things that I'm the most proud of are different? The 2 things actually I'm the most proud of as a person is that my kids still want to spend time with me, and they're 25 and 28. So that's always exciting. And on a local level, what I'm most proud of is I give a talk in my hometown, everybody shows up, which really means a lot, that the people who really have the highest potential of saying, look, he's my competitor. Why do I want to do anything? Are willing to come to support me.
Everybody should come to your talk, especially you pass candy during your talk. So
I do bribe people. That's true.
That's even better. And so, how do you want to be remembered? A good dad, a good physician, and the guy who brought Blender to every meeting.
Absolutely. I think all those work. I mean, I'll take any one of the three. If it puts a smile on your face, and if you can remember some of the things we talked about, hey, that's great.
No, you're awesome. Thank you, Michael, for excellent discussion, and thank you to our audience for listening in. To earn CME credit, visit medittalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindigocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.